Hi everybody, and welcome to our module on ovarian germ cell tumors. An easy way to remember all the different kinds of ovarian tumors is to divide them into three groups based on the ovarian structure from which they come from. So tumors that come from the oocytes or eggs are called germ cell tumors. That's what we'll talk about in this video. In another video, I talk about sex cord stromal tumors, which derive from the supporting cells of the ovary. And then I have another video where I talk about surface epithelial tumors, which are called adenomas and carcinomas. One of the most important things to always remember about germ cell tumors of the ovary is that they tend to occur in young women, usually 10 to 30 years of age. And this is in contrast to most ovarian tumors, which usually occur in older postmenopausal women, especially the most common type, the epithelial cell tumors. The other thing to remember about germ cell tumors is that germ cells normally grow into placental tissue and fetal tissue. So germ cell tumors often have many characteristics of placental and fetal tissue. For example, the fetus can generate AFP and the placenta can generate beta-HCG, and many of these tumors often do this. We'll talk about that in the next few slides. In addition, the tumors can look like any normal germ cell derivative. So for example, germ cells normally grow into the germ layers, and a tumor of the germ layers in the ovary is called a teratoma. If the germ cells themselves become cancerous, this is called a dysgerminoma. Germ cells can normally grow into the yolk sac in the fetus, and if the yolk sac becomes a cancer, this is called a yolk sac tumor. And then the germ cells can also grow into placental tissue, and these types of tumors are called choriocarcinoma. We'll start by talking about teratomas, which are the most common overall ovarian germ cell tumor. And teratomas contain elements from all three germ layers. So inside of a teratoma, you can find some cells that derive from the ectoderm, like skin cells and hair follicles. You can also find cells that come from the endoderm, like lung and GI cells, and you also sometimes find cells that come from the mesoderm, like muscle and cartilage. There is a benign form of an ovarian teratoma, which is called a dermoid cyst, and there's a rare malignant form called an immature teratoma. And we'll also talk about the fact that there are rare monodermal forms, meaning they contain only one germ layer. We'll start by talking about the benign form of teratoma of the ovary, which is called a dermoid cyst. It's also sometimes called a mature cystic teratoma. This tumor gets its name because the word dermoid means skin-like, and in addition, they are usually cystic, so they are skin-like cysts. The reason they are described as skin-like is because they often contain hair, squamous cells, and sebaceous oily material, just like you would find in the skin. In addition, the walls often contain calcification, which you can see by ultrasound, and that's because they often contain tooth-like material. This is a picture of a dermoid cyst on the screen here. You can see that it's hollow and therefore cystic. You can also see that it contains hair cells, and you can also see the oily sebaceous material. Dermoid cysts are usually asymptomatic, so in a board question, this is most likely going to be described as a young woman or girl who presents with a mass in her pelvis but has no symptoms at all. They are usually unilateral, although in a small minority of cases they can be bilateral. And they're usually diagnosed by ultrasound because they have features that are very easy to see by ultrasound. For example, the tooth-like material in the wall of the cyst has calcium, which is bright white on ultrasound, like this circle of calcium here. So you can see that, and then you can see the black cystic space. So when you see features like that in a young woman with an asymptomatic mass, it's most likely a dermoid cyst. Now, I told you these are benign tumors, but they're usually removed surgically. So why is that the case if they're benign? Well, the reason is because there are a number of complications that can occur if dermoid cysts go untreated. First of all, they can lead to ovarian torsion. Secondly, the tumor can rupture and tumor material can spill into the abdomen, and that can cause peritonitis. And then finally, there's a small risk that some of the cells in the cyst will undergo malignant transformation. Any of the elements of the dermoid cyst can become malignant, but what you should know for step one of your boards is that the skin cells are the cells that most commonly become malignant if a dermoid cyst is left untreated. This leads to squamous cell carcinoma if you don't surgically remove a dermoid cyst. Stroma ovarii is a specialized subtype of teratoma. These teratomas contain mostly thyroid tissue, therefore they're often called monodermal because they contain only elements of a single germ layer. Rarely, in less than 10% of cases, they can cause hyperthyroidism by releasing thyroid hormone. This is a picture of what they look like under the microscope here. You can see these red circles that resemble thyroid follicles and contain thyroid hormone. So although this is a very rare tumor and it only rarely causes hyperthyroidism, the classic board case you should know about is for a young woman to present with hyperthyroid symptoms and an ovarian mass. She likely has a stroma ovarii. There is a malignant version of a teratoma that can occur in the ovary. It's called an immature teratoma. These tumors are much more rare than the benign version of teratomas, the dermoid cyst. In contrast to a dermoid cyst, these are usually solid masses, so they're not cystic. They contain immature fetal tissue and cells. Most commonly, they contain immature neural cells, neuroepithelial cells. When you look under the microscope, this is the type of cell that's usually seen in the most abundance. That's something they like you to know for your boards. But besides the neural tissue, you can see elements of all three germ layers. So in a board question, this is also going to be an ovarian mass in a young woman, but instead of a cystic, dermoid cyst-looking teratoma, it's going to be a solid mass, and they're probably going to tell you that there are elements of all three germ layers present. Our next germ cell tumor of the ovary is a dysgerminoma. This is the most common malignant germ cell tumor of the ovary, and it has the same characteristics as a seminoma in male. The two tumors are identical, except a seminoma develops in the testes and a dysgerminoma develops in the ovaries. Also, as we'll talk about in another video, seminoma is much more common in the testes compared with dysgerminoma in the ovaries. These tumors are unilateral in 90% of cases, and what you should know about dysgerminoma of the ovaries is that in many cases these tumors produce enzymes or hormones which can be used as tumor markers. So for example, dysgerminomas sometimes make lactate dehydrogenase, sometimes they make placental alkaline phosphatase, and in a rare number of cases they even make beta-HCG. These things aren't useful for diagnosis. However, if you identify an elevated level in a woman who has a dysgerminoma, you can then use it as a tumor marker. The level should fall after treatment, and if it begins to rise again, it suggests a recurrence of the malignancy. And just like seminomas in males, these tumors tend to be highly responsive to treatment, and a cure is likely. Under the microscope, dysgerminomas have a classic histologic appearance, just like seminomas in males. What you see are undifferentiated germ cells that look like these nests of large cells that have clear cytoplasm with the nuclei in the center, and often these cells are described as having a fried egg appearance. This is an example of the histology of dysgerminoma shown on the screen here. Our next tumor is called a yolk sac tumor. It's also called an endodermal sinus tumor. It's kind of annoying. You just have to remember both names. This is a rare malignant germ cell tumor of the ovary. It gets its name because it derives from extraembryonic yolk sac cells. Shown on the screen is a picture of the embryo during early development. Recall that it has an amniotic cavity and also a yolk sac. Much of that yolk sac will go on to develop the gut tube and the GI tract, but some of it will become extraembryonic, meaning outside of the embryo, and those are the types of cells that are found in yolk sac tumors. It's called an endodermal sinus tumor because under the microscope the cells look similar to the endodermal sinuses of the yolk sac in rats. And one of the things you definitely want to remember about this tumor for your boards is that these types of tumors tend to secrete alpha-fetoprotein, and that's because AFP normally derives from yolk sac cells. And the way I've always remembered this is that the word yolk sac has sac in it, and the A in sac is for AFP. You can use that if you wish. It's always helped me to remember that AFP is associated with yolk sac tumors. These tumors are large, solid masses, and they often develop necrosis and hemorrhage. So for this reason, they commonly present with abdominal pain because of the necrosis and hemorrhage and inflammation. So the classic presentation is a young woman or girl with a large pelvic mass and abdominal pain and a high level of serum AFP. That is likely a description of a yolk sac tumor. And just so you're aware, these also occur in the males in testes. The testicles can develop a yolk sac tumor as well. There's a classic pathologic finding in yolk sac tumors called a Schiller-Duval body. It's a blood vessel like this pink thing in the middle of the screen here, surrounded by cancer cells on the outside. If that is seen, it is pathognomonic for a yolk sac tumor. These structures are described as glomerular-like or glomeruloid because they have some similarities to the glomerulus. But the main thing to remember is when you see a blood vessel surrounded by cells like this, they're showing you a Schiller-Duval body in a yolk sac tumor. Last ovarian tumor is a choriocarcinoma. Now, choriocarcinomas often occur in the uterus. They're a rare malignant gestational neoplasm, and I talk about these in the video on gestational tumors. In that situation in the uterus, they often occur following a normal or molar pregnancy. They can, however, also occur in the ovary as a germ cell tumor. They can also occur in the testes as well. When they do, they share many similarities with the uterine tumors. So what you see under the microscope are syncytia trophoblast and cytotrophoblast cells, basically the cells of the placenta with no formation of villi. Just like normal placental tissue makes HCG, choriocarcinoma, which is a tumor of placental cells, can secrete human chorionic gonadotropin, or HCG. This can be useful for diagnosis. You can measure the level of beta-HCG. It's usually very high in a young woman or girl with choriocarcinoma. In addition, HCG can mimic LH, and in a girl who has not yet entered puberty, this can stimulate the ovaries to produce estrogen, and this can cause precocious puberty. So a classic presentation would be a young girl with precocious puberty who has a mass in her pelvis. This is highly suggestive of choriocarcinoma. In addition, estrogen from the ovaries stimulated by high levels of HCG can lead to endometrial growth and irregular vaginal bleeding. And then finally, HCG also shares many similarities with TSH, so it can mimic TSH, and this can lead to hyperthyroidism. This is a slide from my video in the endocrine section on the pituitary gland, and I just want to remind you that there are 4 hormones that are dimers and share a common alpha subunit. Those 4 hormones are HCG, TSH, LH, and FSH. So if a choriocarcinoma produces lots of HCG, this can mimic TSH and LH. That can lead to hyperthyroidism, and it can also stimulate the ovaries to begin producing estrogen. And the last thing I'll mention about choriocarcinoma of the ovaries is that these tumors are aggressive and they spread hematogenously. They're often already in the lungs, liver, and bone at the time of diagnosis, and they tend to be more difficult to treat and cure than the placental tumors. The placental tumors usually respond more easily to some forms of chemotherapy. And that concludes our video on ovarian germ cell tumors.